This recording will cover peritonitis. Peritonitis is a life-threatening acute inflammation and infection of the visceral, parietal peritoneum and endothelial lining of the abdominal cavity. Normally, the peritoneal cavity contains about 50 mL of sterile fluid, which prevents friction in the abdominal cavity during peristalsis. When the peritoneal cavity is contaminated by bacteria, the body first begins an inflammatory reaction, walling off a localized area to fight the infection. The body's immunity is immediately affected by this local reaction, which involves vascular dilation and increased capillary permeability, allowing transport of leukocytes and subsequent phagocytosis of the offending organisms. If the process of walling off fails, the inflammation spreads and contamination becomes massive, resulting in diffuse or widespread peritonitis. Peritonitis is most often caused by contamination of the peritoneal cavity by bacteria or chemicals. Bacteria gain entry into the peritoneum by perforation from appendicitis, diverticulitis, or peptic ulcer disease, or from an external penetrating wound, a gangrenous gallbladder, bowel obstruction, or ascending infection through the genital tract. When diagnosis and treatment of peritonitis are delayed, blood vessel dilation continues. The body responds to the continuing infectious process by shunting extra blood to the area of inflammation. Fluid is shifted from the extracellular fluid compartment into the peritoneal cavity, connective tissues, and GI tract. This shift of fluid can result in significant decrease in circulatory volume and hypovolemic shock. This shift of fluid can result in a significant decrease in circulatory volume and result in insufficient perfusion of the kidneys, leading to acute kidney injury with impaired fluid and electrolyte balance. Assess for signs and symptoms of these life-threatening problems. Peristalsis slows or stops in response to severe peritoneal inflammation, and the lumen of the bowel becomes distended with gas and fluid. Fluid that normally flows to the small bowel and colon for reabsorption accumulates in the intestine in volumes of 7 to 8 liters daily. The toxins or bacteria responsible for peritonitis can also enter the bloodstream from the peritoneal area and lead to bacteremia or septicemia, which is a bacterial invasion of the blood, a life-threatening condition when the body's immunity is compromised. Respiratory problems can occur as a result of increased abdominal pressure against the diaphragm from the intestinal distension and fluid shifts to the peritoneal cavity. Pain can interfere with respirations at a time when the patient has an increased oxygen demand because of the infectious process. Again, bacteria such as E. coli can be responsible for causing peritonitis. Chemical peritonitis results from leakage of bile, pancreatic enzymes, or gastric acid, all of which greatly alter the patient's immunity. When obtaining a history, ask the patient about abdominal pain and determine the character of pain, location of the pain, and whether the pain is localized or generalized. Ask about a history of low-grade fever or recent spikes in temp. The patient with peritonitis most often appears acutely ill, lying still, possibly with the knees flexed. Movement is guarded, and he or she may report or show signs of pain, such as facial grimacing, with cough or movement of any type. During inspection, observe for progressive abdominal distension, often seen when the inflammation markedly reduces intestinal motility. Auscultate for bowel sounds, which usually disappear with progression of the inflammation. The cardinal signs of peritonitis are abdominal pain, tenderness, and distension. For patients with peritonitis, assess for abdominal wall rigidity, which is a classic finding that is sometimes referred to as a board-like abdomen. Monitor the patient for a high fever because of the infectious process. Assess for tachycardia occurring in response to the fever and decreased circulating blood volume. Observe whether he or she has dry mucous membranes and a low urine output with third spacing. Nausea and vomiting may also be present. Hiccups may occur as a result of diaphragmatic irritation. Be sure to document all assessment findings. Please review the chart in your textbook that lists key features for peritonitis. White blood cell counts are often elevated to 20,000 with a high neutrophil count. Blood culture studies may be done to determine whether septicemia has occurred and to identify the causative organism to enable appropriate antibiotic therapy. The healthcare provider may request lab tests to assess fluid and electrolyte balance and renal status, as well as H&H. Oxygen saturation and carbon dioxide monitoring may be obtained to assess respiratory function and acid-base balance. Abdominal X-rays can assess for free air or fluid in the abdominal cavity, which indicate perforation. The X-rays may also show dilation, edema, and inflammation of the small and large intestines. Priority problems for the patient with peritonitis include potential for infection, potential for fluid volume shift due to fluid moving into interstitial or peritoneal space, and acute pain. Non-surgical management for infection involves assessing vital signs frequently, noting any changes that may indicate septic shock, such as unresolved or progressive hypotension, decreased pulse pressure, tachycardia, fever, skin changes, and/or tachypnea. Monitor mental changes for any sign of confusion or altered level of consciousness. Practice proper hand washing and maintain strict asepsis when caring for wounds, drains, and dressings to decrease chance of infection. Observe and document wound drainage. Administer broad-spectrum antibiotics as prescribed to treat known or potential pathogens. Apply oxygen as ordered and according to the patient's respiratory status and oxygen saturation via pulse oximetry. Surgery focuses on controlling the contamination, removing foreign material from the peritoneal cavity, and draining collected fluid. Exploratory laparotomy or laparoscopy is used to remove or repair the inflamed or perforated organ, such as an appendectomy for an inflamed appendix. Before the incision is closed, the surgeon irrigates the peritoneum with antibiotic solutions. Several catheters may be inserted to drain the cavity and provide a route for irrigation after surgery. If an open surgical procedure is needed, the infection may slow healing of the incision, or the incision may be partially open to heal by second or third intention. These wounds require special care involving manual irrigation or packing as prescribed by the surgeon. If the surgeon requests peritoneal irrigation through a drain, maintain sterile technique during manual irrigation to prevent further infection. Monitor the patient's level of consciousness, vital signs, respiratory status, and I's and O's at least hourly immediately after abdominal surgery. Maintain the patient in a semi-Fuller's position to promote drainage of peritoneal contents into the lower region of the abdominal cavity. This position also helps increase lung expansion. The healthcare provider prescribes hypertonic IV fluids and broad-spectrum antibiotics immediately after establishing the diagnosis of peritonitis. IV fluids are used to replace fluids collected in the peritoneum and bowel. Monitor daily weight and I&O carefully. An NG tube decompresses the stomach and the intestine, and the patient is NPO. Peritonitis causes significant alteration in comfort. Interventions to manage pain focus on drug therapy. Administer analgesics and monitor for pain control. Document all pain assessments and interventions implemented to promote comfort thoroughly. When discharged home, assess the patient's ability for self-management at home with the added task of incision care and a reduced activity tolerance. Provide the patient and family with written and oral instructions to report the following problems to the healthcare provider immediately. These problems include unusual or foul-smelling drainage, swelling, redness, or warmth or bleeding from the incision site, a temp higher than 101 degrees Fahrenheit, abdominal pains, and signs of wound dehiscence or ileus. Please make sure that the patients understand how to care for any wounds that they have, whether it's packing or irrigation. If a patient needs assistance with ADLs, a home care aid or temporary placement in a skilled care facility may be indicated. Make sure the patient understands any medications that have been prescribed. Teach patients to refrain from lifting for at least 6 weeks after an open surgical procedure. Patients with peritonitis may benefit from a social service consultation. Social workers can help patients locate the most appropriate and affordable supplies that will be needed for ongoing care.